So good afternoon, everyone. I would like to welcome you to this first webinar of the JoinHealth Spring Series. This is a collaborative initiative from the Health Cluster Portugal and EIT Health, herein represented by Miguel Amador. And our aim with these webinars is to bring awareness over some topics of interest and to promote an environment for open discussion. So we would ask you to feel free to ask questions to our panelists here today using the Q&A box. Today's webinar will be about health data interoperability, and I will show you just a brief summary of today's agenda. We will have first Ricardo Correia, who will give us an overview about health data interoperability. Why is it needed and how can the major challenges be addressed? And following this presentation, we will have Sara Caçador from Healthy Systems and Pedro Duque from Plux, presenting a case study of some applications of health data interoperability. So thank you so much, all of you, for kindly accepting our invitation. Just a brief note about the presentation slides. So we'll make them available upon request, and for that you'll receive a link to complete a survey after this webinar, where you'll find a box to add your email address in case you'd like to receive the presentation slides. Also, the recording of this session will be available on YouTube a couple of days after the webinar. Now, and without any further delay, we'll move to the first presentation by Ricardo Correia. And Ricardo Correia is an auxiliary professor at the Faculty of Medicine of the University of Porto, where he lectures several disciplines on medical informatics and is currently supervising several PhD and master students. He has a background in computer science and a PhD on integration of hospital information systems, with nearly 200 scientific articles in health informatics. And he has collaborated on the implementation of several health information systems. He's a member of several health informatics standard organizations, such as HL7, OpenEHR, among others. And he is also the co-founder of 3 spin-off companies of the University of Porto, namely Healthy Systems, Virtual Care, and IS for Health. So thank you very much, Ricardo, and the screen is yours. So please share your screen and you may start your presentation.
Hello, can you confirm that you are seeing the
yes.
presentation? Okay. So good afternoon. First of all, I would like to thank you for the invitation, and I hope that in the next 40 minutes or so, I can explain you a little bit of why we need interoperability, why it is so hard to get it, and give some clues on how we could move forward regarding and aiming to get to interoperability in healthcare. The way I organized this presentation is first we're going to talk about the need for interoperability, and I'm going to explain you a little bit about how we currently divide interoperability in 4 levels. I'm going to try to explain you a little bit about 2 standards that are very important currently, which are IHE and HL7, and also talk about some opportunities and challenges. Afterwards, we'll have some time for questions and answers, and then you'll have the other 2 presentations that Patricia just mentioned afterwards, and a final period for Q&A. So because I don't know exactly if the people that are seeing this webinar are aware of what is a national health system, I'm going to start to try to explain you a little bit on how it is organized. And because this help us understand some of the complexities and difficulties of making interoperability in health, not only inside one institution, but also among different institutions. What you see here is, well, an hierarchical representation of the Ministry of Health, and also of other institutions that somehow are related to the Portuguese health ecosystem. And what you can see here is that you have some, what is called in this representation, direct administration. You have the General Secretariat of Ministry of Health, you have IGAS, the Director General of Health, DGS, and you have CICAR. And of course, each of these institutions has its own set of responsibilities, but of course they are all of these institutions have a set of data that they wish to analyze, and sometimes this data comes from other institutions, and also they are obliged to send information to other institutions. So they receive and they send, of course. So the first column is direct administration. The second one is called indirect administration. We have here ACSS, which is normally the institution responsible for instance, billing, refunding hospitals. So more the financial parts of the Ministry of Health normally is dealt with by the central administration of the healthcare system. Also, you have Infarmed that deals with the medicines and medical devices that are possible to be used in Portugal. You have the National Institute of Medical Emergency, the Portuguese Institute of Blood and Transplantation, also INSA. And you have, for each region of Portugal, you have a regional health authority, one for North, Center, Lisbon, Alentejo, and Algarve. And so this last square actually is subdivided in several regions. Okay. Again, think that each of these institutions might at some point want to exchange information with one another. The next column, we have other two institutions, the regulatory entity of health, and one that is very central when we talk about interoperability in Portugal, that is the shared services of Ministry of Health. And it is central because one of its main responsibilities is to take care and create and evolve a large set of the software that actually is used inside hospitals and primary care institutions, among others, but I would say those are the big ones. And then on the column of the health providers, you have all the hospitals, the health local units, and the groups of health centers, and other service providers and pharmacies also. So as you can see, this schema really tries to sum up a lot of different things. For instance, pharmacies, there are hundreds. And so this, if we would divide and put in this schema all the particular institutions, it would be a big schema. And then on the right, you have also things like the professional orders, physicians, dentists, nurses, pharmacists, and patient organizations. Okay, so this somehow describes very briefly the national health system. Again, a lot of possible data exchange is interesting among many different pairs of institutions. Okay, now let's look inside a hospital. So in this schema, the hospital is just one of the squares that we have here. And in Portugal, we have tens of hospitals. So, but just imagine that you are looking for just inside one single hospital. I'm sorry that this is in Portuguese, but this is more for you to have a graphical view. This is how typically a hospital is organized. Okay, I just picked one from the web. In this case, it's from Hospital Barreiro in Montijo. And well, this is typical. You have a set of departments, of clinical departments. Then you have the labs, for instance. You have also the radiology department, and you have other departments that are somehow, they call the support departments, like pharmaceuticals, nutrition, informatics. And then you have, in this case, a lot of different commissions that try to deal with specific issues of the hospital. But as you can see here again, the hospital is subdivided in many different units and departments. And of course, each of these units or department is concerned with its own responsibilities. And this means that it has its own data, its own, many times its own system that needs to be integrated with the other systems that are being used by the other departments. Okay. So as you saw in the first schematics about the NHS, many different types of institutions. And then when you look into one hospital, you see this again. So this is more or less like a fractal view of the NHS. Each time you look a little bit closer into one of these squares, you'll see that it can be, again, subdivided into smaller ones. So just for us to make a fast exercise on the need for communication among these institutions. Just imagine for a moment what type of data exchange could exist between, for instance, a hospital and a regional health authority. Well, for instance, the hospital could be sending the number of available beds, for instance, so that regionally we could manage send patients for one hospital or the other, depending on the available beds. And also the regional health authority could send to the hospital the number of diseases cases in the region, so that, well, the hospital could be aware that, for instance, a particular infection is appearing. So of course there are many other examples. This is just a simple one. Of course, hospitals and regional health authorities want to exchange data. Also, if we look at the hospital and the Infarmed, which is the National Authority for Medicines and Healthcare Products, well, for instance, the hospital could be sending the Infarmed the adverse drug reactions that occur inside the hospital, and also Infarmed could be sending back the list of drugs that can be prescribed that are, let's call it, legal, that are possible to be prescribed inside hospitals. So again, information going from one place to the other. For instance, you could see another type of examples. The SPMS, which is responsible again for some of the informatics of the Ministry of Health, might be interested in receiving from the College Order of Nurses, for instance, a list of the nurses and their professional ID, which is something that typically are the orders of the health professionals that deal with. So they'll be receiving the list of nurses that can be, that have a login, an account to use the systems. Also, for instance, hospital will be sending the list of patient encounters for CSS for reimbursement. And different example, the Portuguese League Against Cancer can be sending information to DGS regarding the results of the cancer screening, and also be receiving the list of people to be screened from the DGS. Well, again, some of these examples, I'm not really sure if they are real or not, but this is just an exercise just for you to understand that the possibilities are many. And these are just some pairs of institutions that I've selected, but I could select many others and still find other opportunities to exchange information. And I guess that you already realize that some of these exchanges are very different from one another. Sometimes you send information about a patient, sometimes you send information about the list of drugs, or work lists like list of information to be screened. So they are of many different types. I'm going to show you a little bit about one work that I've been involved a few years ago now, where we try to understand actually what type of information was going from one type of institutions to the other. Oh, I can give you the reference afterwards. So I'm just going to skip some of these slides. So, but you see here a lot of these different types of institutions. The arrows means that there are actually some information going from one place to the others. And of course, you have clinical information like referrals, exams, or prescription going from one place to the other. As you can see on the bottom right, you'll see that, well, some of this information is actually, the integration is automatic. Others, they are not integrated, but users can jump from one system to the other very easily. So they are not actually integrations. And well, some of the information just goes around using emails or phone calls or letters. So the information goes around, but it's not really an integration also. But again, gives you an idea of the type of information that go from one place to the other. The first one was clinical. Now for demographics, mainly patient identification and professional identification. Also, well, some information regarding statistics. So not really the raw data, but just a summary of the data, so statistics about that data. And also we have information regarding billing, salaries, lists of elements, so catalogs, or indicators of production, for instance. Okay, so many types of information going from one place to the other. Again, let's look now let's look at a hospital, inside the hospital, to see what actually is happening inside the hospital. And here I'd like to stress something. Most of people that talk about integration inside hospitals don't have a clear image of the number of systems that exist inside the hospital. Okay, so I'm going to show you here a real list of the systems that you find on one particular hospital in Portugal, but this is the normal thing for you to find on the other public hospitals in Portugal. Okay, so in this case, in this list, you'll find more or less 50 different information systems. And again, each pair probably will end up to have a use case where you want to exchange information from that information system to the other. So I'll just skip the slides, not so that we don't lose too much time here. But you can see this is the first page of the list of these systems that exist on one hospital. Second page, third one, fourth one, and fifth. Okay, so it's a long list. Okay, so now that you saw how big and complex and different it's the NHS and how complex can be inside the hospital, can we really expect that interoperability to be simple? Well, no. This is not really like many other sectors, when sometimes you hear people saying that, well, if it is possible for us to put banks to communicate with each other, how come we cannot do it so easily inside healthcare? Well, because it is much more complex, and everybody that actually works in this area for many years will understand this is not the same thing. It's much more complex. The institutions are very different. Inside each institution, there's a lot of different departments with different concerns and very specialized, and so it's much harder. So how did the interoperability grow? So how it has been the evolution, and what are our current expectations? So this schema, I think it helped us realize something. We started many years ago with the idea that we could have one single system inside, for instance, a hospital. So this is the monolithic view, and that system will have everything. Well, this is not possible, and so because there are many different specialities inside the hospital. For instance, you have an X-ray machine. The X-ray machine has its own information system, and that information system is not the patient record. So you'll end up just with this very simple example. We have already two systems: the X-ray information system and the patient record system. And so after this first monolithic view, we started creating all of these very specialized systems that we call them islands in the beginning, because most of them did not talk to each other. So they were islands regarding communication. Afterwards, and this is more or less where we are now, we started putting some of these islands to communicate with each other. And so this is where we are now, where we have, for instance, the radiology system that talks with the patient record, that talks to the laboratory system, for instance. And so we have many communications point to point where you actually manage to have some interoperability. But what we actually wanted to have in the future is an infrastructure where all of the systems are like these small balls inside this cube, which is my institution. And I can take out one of these information systems, input another one, and it will more or less automatically start talking with each other. Okay, this is more or less the view that everybody's aiming for, which is not easy, of course, but we are, I would say, currently trying to move from the some communications within messages into this idea of this infrastructure of advanced standards, where the clinical concepts are represented in the same way in different information systems, so that we can easily exchange information. I brought to you one definition that I've just heard a few weeks ago that I really like this one, because it gives us an idea of how, what are our expectations and how difficult it is to get it. So regarding to Thomas Bill, which is a very known expert regarding interoperability, the level of interoperability between distinct components of an information processing environment is proportional to their ability to correctly communicate their internal semantics. This means that they need to communicate what their own data means with other systems without special measures, without having to do mapping and stuff like that. So that you can easily send information from one system to the other and be and believe that the other system will understand the same thing as you do regarding that data. This is very hard to do, and we are still very far away from this. So how can we now divide the interoperability in different levels and concerns? I followed here the HIMSS definition, and according to HIMSS, interoperability can be divided into 4 different levels. The foundational level, where it's more technical regarding informatics, and it mainly concerns with information securely going from one place to the other. The second level is called structural, where you define, for instance, the format, the syntax of the messages, and how the data is organized. And actually, when you send an information, a message, it explains you, well, the first field, what it means, the second, the third, and so it has already some semantics, but it's more about the envelope, about the structure of the message. The third level deals with semantics mainly, and it's typically done using terminologies and coding systems. And so the idea here is to have public available value sets that are known and shared by the different organizations, so that when, for instance, we have a code for a particular diagnosis, everybody understands that code and that the diagnosis the same way. The fourth level, and this is fairly new regarding the interoperability levels, is the organizational level. And this includes the governance of the exchange of information, the policies, and all the social, legal, and organizational considerations regarding this exchange of data. So it's less technical regarding informatics or health informatics, but again, is more concerned about how the institutions actually should be exchanging, if it's possible to exchange information or not, if it's legal or not, if it's adequate or not. Now, just a few more comments on some issues for each of these levels. Regarding the foundational, so the first one, we still find some legacy systems that use proprietary computer formats that are not actually appropriate. And for instance, there are still systems that promote that instead of exchanging messages or having services, well, they still promote direct database links, which is something that we shouldn't be doing now. It shouldn't be possible to do that, but it still is in many of the Portuguese hospitals. So this is, I would say, one of the critical issues regarding this level. Another thing is that for this level, the people that should tackle with these issues are mainly IT personnel. So you don't really need people that are very specialized in health informatics. It's more IT personnel or software developers. Regarding the structural level, we have still many systems that do not use standards, like the ones I'm going to talk about, HL7, for instance. And typically, I would like to also to stress that many new programmers that come into this area think that the standards, the general standards, the generic ones that are not for health informatics, that they learn at faculty, for instance using REST or SOAP, are enough. Well, they are not. They are useful, you can use them, but you need to use more standards that are more of a high level, that work on top of REST and SOAP. For instance, HL7 V2 or HL7 Fire. And so for this level, you already need people that have some type of knowledge regarding health informatics, and in particular, experience in integration is also very useful for people to work on this level. The next one for semantics, so main problem is that you have many different terminologies. For instance, in Portugal, you have one set of codes for doctors and another one for nurses, for instance. And also you have another problem that terminologies evolve during time. So we need version control. We need to know that that particular diagnosis code was coded in a version of ICD, for instance, of 10 years ago. And it might have a different meaning today. So we need to also, it's not enough to store the code, you need to store the version of the terminology of that code. Also, we have a huge problem worldwide of lack of consistency in storing this data. So it's fairly easy for you to have two health professionals that for the same patient, they will select different codes, okay? So for this level, we need health professionals, in particular, specialists in clinical coding, and also health informaticians, in particular, people working on health ontologies and on how we can map from one coding system to the other. Regarding a more organizational level, some of the issues today are how to deal with security and trust between organizations, and how to deal with cross-border workflows. So patients, for instance, that have treatments in different organizations, and so we need to have a flow of information that somehow supports this flow of the patients also. So here we need to involve specialists like legal experts, because of who should be accessing data or not. Also the managers of the health institutions, people that come from public health area, and experts working, for instance, with patient pathways. So as you can see, for us to have a good project on health interoperability, we need different people in different levels, different expertise. Now I'm going to talk to you about one particular set of standards, which is called IHE. IHE means Integrating the Healthcare Enterprise. And IHE is it's an initiative by health professionals and industry to improve, well, the way computer systems and healthcare shares information. So it uses several other standards like DICOM and HL7. And the idea is that systems that are developed in accordance with IHE, they can communicate with one another in a way that is much easier, and so they can use information more effectively. So just for you to have an idea, so IHE is here in the middle. You have all these sets of standards on the left, and IHE somehow tries to use, well, most of those and make them make sense in one particular e-health project. Okay. Another thing that is important for you to know about IHE is actually in Europe, the European Commission stated that we should try to use the IHE in public procurement. This means that, for instance, if a hospital makes a tender, the hospital should put in the tender that, well, the suppliers have to conform with the standards of IHE. Okay, and for you to understand a little bit better what those standards are, I'm going to give you an example. We are going to look a little bit closer into one particular, which is this one, HELTW, laboratory testing workflow, just as an example. As you can see here, the number of profiles that the European Commission stated that should be used because they are mature enough to be used is these 27, and we're going to just look into one of those as an example. So when we look at one of these profiles, what can we see? The profile itself, well, the information is publicly available, this one, and this profile somehow describes the different actors for one particular profile, in this case, laboratory testing workflow. And here you can see on the documentation of the profile that it says, well, the actors involved in the laboratory testing workflow are the order placer, order filler, automation manager, and order result tracker. Well, this, of course, it's for each hospital, for instance, will be a particular software program that is doing the role of order placer, order filler, automation manager, or order result tracker. But here, everything is described in this way regarding the roles that they might have. Typically, here in this schema, you can see already the association. The order placer and the order result tracker is performed by the clinical information system. The order filler is performed by the lab information system, and the automation manager is performed by the lab automation system. So, but this gives you, again, a first idea on the exchange of data. Then the standard describes a little bit more detail what type of transactions occur between these actors. And we can actually drill down again. And for instance, we are going to look a little bit more closer to this first one, placer order management. And here you can see that you have another set of schemas that describe in particular how can this, what type of messages need to be exchanged in that particular transaction placer order management. Okay, in this case, for instance, I've brought the normal process of placer order and also another use case, which is the cancellation by order filler. Okay, so and you have another, and we have others, but as you can see, for each transaction, you have all these processes that are already predefined. So the standard describes all of this. And again, if afterwards you look at one of these particular arrows of messages, you'll find that, well, for each one of those, you have one message, one type of message. Here we have an example that I just copied from the light documentation of SPMS as an example of that first line, which is an OML message for ordering. And so what you can see is that with the AHE profiles, you can start with a very general description of how a lab works. And then the standard helps you to identify the actors, the transactions between those actors, and for each transaction, what are the processes involved. And then for each of the arrows, for each of the communications, well, you'll have an example of a message, a template of a message that can be used for that particular exchange of information. Okay, so these standards are very useful for you. For instance, if you wanted to put the different systems in your that work with the lab in your hospitals to work together appropriately, well, you could use this IHE profile and do all of this with your software suppliers to see if they are following the IHE profile for labs or not. Okay, now let's look a little bit about, because I've shown you a message, an HL7 message, which is something that is a little bit scary for the first time. I'm going to try to explain you a little bit how we can read that message. So HL7 is one of the standards that it's more used in healthcare. HL7 and ICOM are probably both standards that are more used in healthcare. ICOM is is more for imaging, HL7 for everything else. And I would like just very briefly tell you that, well, HL7 started many years ago. The first versions are from the early 90s. Well, the version 2 is the one that is still more used in Portugal, but we are currently now starting to use another version called Fire. In the middle, we have HL7 version 3 that didn't have that many people using. HL7 CDA, we don't have that many people using also in Portugal at least, but Fire is really getting more companies to use. And so, well, if you are new to this area, I would say that, well, you need to still learn a little bit about HL7 version 2, but it's probably a good thing that you invest on HL7 Fire. Okay, now let's look a little bit about HL7 version 2. In the other two presentations after mine, you'll hear more about HL7 Fire. Regarding HL7 version 2, you'll have major message types, which are these ones on the left. You have messages for admit, discharge, and transfer patients, for billing, for financial transactions, medical document management. And so we have all of this for pharmacies, for labs, for observation results. And each of these major message types, for each one of those, you have then, they are subdivided in smaller ones. For instance, regarding ADT messages, so admission, discharge, transfer, you'll find information about messages to admit visits, for patient transfer, discharge, patient registration, pre-admission, information update, and so on, and for canceling also. Okay, this first one, the acknowledge, is used for when one system sends a message to the other, the system that receives the message is obliged to send an information back, which is called an acknowledgement, saying that, confirming that it has received and understood the message that it was initially sent. So these are the acknowledgements. So for each of these types, okay, you'll get messages like this. So this is an example of an admission visit notification. Okay, and I'm going to try to at least explain a little bit how we can read these messages. So first of all, the type of the message is somehow described in the first line, and it's here, what it's called, so ADT A01. So this is the type of message, and this helps you understand the following lines. This is how computers understand what should be receiving and in the next lines. In this case, you'll find here what we call segments, and we have 7 segments. It's easy for you to identify those because the first letters are in first 3 letters are in bold. So the first segment is MSH, the second one is EVN, PID, PV1. You have a couple of segments called OBX, and then LA1. So this would be more or less like you send a letter, and each of the segments is a phrase or a paragraph, something like that. Okay. And now if you look at one particular segment, we can see that we can actually, well, understand a little bit of what's going on. For instance, PID means patient identification. So in this segment, we try to tell information about the patient. And you'll see here that, for instance, the first part, we are saying what is the number, the national patient number of this patient. Okay, we are saying that, well, is called, the number is 567824445, and the institution that is responsible to issuing these numbers, it's the SNS from Portugal. Okay, again, in the further on, we have like the address, for instance, that is also here highlighted. And if you, well, make some effort, maybe you'll you'll figure out the rest of the fields that are here. Another one we can look at, for instance, an OBX. OBX is for observation, and here you can see that we have described the height of the patient in inches. So we have here that this particular patient has 71 inches in height, and it's saying that, well, this is inches as in the ANSI standards, and again, this is very important. As you can see here, we don't exchange just the number 71. We also exchange the how it is measured, and so with the units are very important so that the system that receives this information understands properly. Okay, so again, very in a very well summarized way, you can see that we have many different institutions in the national health system. Each one of these institutions has many departments and information systems inside. For each of these institutions, for each of the departments, you might have many different transactions for a particular workflow, like the lab or radiology or whatever. Many of these can then be subdivided in many different processes. And then those processes are again translated into many different message types with different segments, and then coding systems and so on. So it's hard to do integration, a lot of complexity around all of these needs for data exchange. So now I'm going to describe, just to end up, a few challenges and opportunities in this area. The first thing I would like to tell is that the future of healthcare is built on back of data, and with data coming from health system from many different places, it is important that every healthcare organization to have an understanding on the future of interoperability and integration. So the ability to exchange healthcare information between systems in a timely and understandable manner, and this understandable is very important and hard, has always been very important, but as the volume and type of health-related information increases, well, it's getting more important and difficult to achieve. A way for us to understand how this is getting more and more important is if we look at the market growth that is expected for the next years. You'll see that we have a growth of 10% per year in North America, Europe, and Asian Pacific, and less in Middle East and Africa and South America, but still there are very high percentages of growth, and it's steady for each year. So as a final slide before the Q&A, I would like to say that in my opinion, some of the interoperability drives that you have currently that you need to tackle with when you talk about interoperability is GDPR, in particular traceability, because institutions now need to know with whom do they exchange information because of the GDPR. So we need that. We need traceability for all the communication. So this is one very important issue regarding interoperability. Also, there are many different institutions in Europe trying to create data lakes. And for that, you need to get data from many different sources. And so we need to know how we can map information from different sources, for instance. Also, there is a very big opportunity regarding process mining, because if you look at how different systems exchange information inside the hospital, for instance, you'll understand how the organization works also. You understand when one particular health professional asks for an exam, when the exam is made available, how long it takes for the exam actually to be viewed. So all of this is very interesting, and it's possible for us to do software based on that, but also it forces interoperability between systems. Also, of course, it's something that everybody wants to do, machine learning regarding healthcare, but for you to do it properly, you need to understand the data. And so we need to have an idea, to have semantic models of when you get information out of one system that it describes what it means. So this is, and again, it tackles with interoperability here. These last 2 points are more or less to make a bridge to the presentations of my colleagues after the Q&A, which are another couple of drives regarding home monitoring and wearables, which are things that are really exploding, and a lot of different institutions see that it would be useful if they can get this information and bring this information into their own electronic health records inside the institutions, but we need to solve these interoperability issues also. And okay, I think I've finished the slides, so thank you for your attention, and then I'm willing to answer some questions.
So thank you, Ricardo, for your presentation. We'll have now time for some questions and answers. So if you have any specific questions, I will ask you to drop them in the Q&A. So Ricardo, again, thank you very much for this summary of such complex system, and for putting forward some of the major hurdles and current challenges in this field. So this has very important repercussions for the future of healthcare and how we manage it, for sure, as you just mentioned. I will ask Miguel's help for the management of this interaction with the virtual audience. So
yes, so we have a question. I don't know if you can read it or not, from Jose Correa, asking about the HL7 V2 and the fear gaining adoption. When do you have more detail, or how many healthcare systems still use the V2, and how do you expect the fear to become the dominant standards?
Okay, I would say that I would be surprised. I think that every healthcare institution today still has at least one HL7 version 2 integration. Okay, at least one. So this is really something that is very common on every health institution. And well, a few have already some HL7 Fire, but I would guess that from, I don't know, 25% to 35% might have already some Fire. Very small, very, well, just one case, but it's getting, it's growing. And actually, one of the reasons why it is growing is that it's particularly useful to tackle with, to integrate things like wearables and apps, which is something that is also a drive currently. So also these new things call for Fire, and so the newest integrations, well, they also are going to use Fire. But HL7 will be around for many years. Because you know that, like in many other scenarios, when things are working well, nobody wants to mess with those. And you have many different integrations working with the HL7 V2 that, well, do their job, and so nobody will want to change those.
So Ricardo, I have a question. It might be a naive question because it's not at all my background, but how do you foresee, or how when you go international, at the international level, how much more complex does this get? So I mean, do you when you go interoperable abroad, is it different, or when we have to integrate what we're doing in Portugal with other countries in Europe? So is it a major challenge, or if we have things well prepared, in the Portuguese health system, it will be easy to go abroad and communicate with other systems abroad.
I would say that if you don't use these standards, well, it's going to be a mess, because it's imagine it's going to be hard for others to adapt to the thing that you invented yourself. It is possible, but it takes longer. It's more expensive, so it's not really a good idea. So if you are using already these standards here in Portugal, it's easier for you to go abroad. Having said that, of course, we have also in some of these other countries, you'll find some local standards. Let's call it like this. So you might still need to adapt to some local particularities. But it's much easier if you use the international standards. And another thing, Patricia, is that I really think that people that want to take their technologies abroad, they should get involved with the international bodies of standardization. They should get involved with the people from HL7, from FHIR, from the terminologies, from DICOM, if it's more of the imaging, because then you'll have an opportunity to test your things with companies from abroad before going to market. Okay.
Yeah. So to get involved with the local communities that are in touch with international communities to start getting involved. Okay. I don't know if are there any other questions in the Q&A?
None from the audience, but if I can make a question, that's there is a lot of this debate about the ownership of data, and where you mentioned the GDPR and so on, and the purpose of how patient data is patients' ownership, so they can claim it. But at the same time, there is these notes and this data that is created by medical doctors and staff that is hospital data. How these kind of standards in some way account for this separation? Like if I as a patient request the hospital give me my data, how the hospital knows what is patient data that is legally their right to claim, or is proprietary hospital data, and how the probabilities is considered on this kind of standards for you?
Miguel, this is more or less like you just opened the Pandora box. So I'm not really sure on how much time do I have to answer, but let me just.
A minute, so it's just
okay.
Be the next webinar on
okay.
this topic.
So let me just give you some insights on this. Most of the people that say the information is from the information is of the patient, in my opinion, they don't know what they are talking about. It's a sentence that is very nice, but it ends there. Typically, the institutions are the one responsible for the data. For instance, if you go to a hospital, the hospital is responsible for my data, but actually, it's not really the hospital that owns the data. The guys that own the data are the software developers, the guys that are in charge of the database. Those are the ones that own the data. And the way I say this, because those are the only ones that can delete, update, insert, and the hospital as a whole does not have that ability. Maybe the guys from the IT department might have. So it's important for us to understand what we say. The guy that owns the data, what does that mean? It means that he has the responsibility of, if something happens to it, it is the institution responsible. Well, then it's the hospital. If the guy that actually is able to delete everything without leaving a trace, well, those are the suppliers, the software suppliers. The patient in all this schema, I don't know what it has. It has very little, maybe just hope. It would be a good thing. And I think that is something that we could move forward in that direction, but it's not very easy. And actually, Miguel, we don't have that, in my opinion, in any other setting. We don't have it in healthcare, and we don't have it anywhere. Actually, it's wrong. I have it in healthcare when I have those books with the vaccines still written in hand. Well, there you own your data, but you'll need to go back to paper. So I'm not really saying that this is a good idea, but I think that we need to tackle with that. But we use a lot of sentences and a lot of legal that it's not compatible with the reality. So sorry, not to give him a final good answer to that, but
I think we need to move on the general.
Yeah, so thank you once again, Ricardo, for this presentation and for this discussion. So we'll now move to the next part of the webinar, where we'll hear from Sara Caçador from Healthy Systems and from Pedro Duque from Plux about the application of health data interoperability standards in specific projects, namely in a collaborative project that is being developed under the coordination of the Health Cluster Portugal through its Smart Health Network subcluster, and that is devoted to the development of a chronic disease management platform. About these two speakers, Sara Caçador is a functional consultant in interoperability at Healthy Systems. She has a degree in biomedical sciences and started recently a master's in medical informatics with a focus on FHIR. And she has been participating in information system integration projects in several Portuguese hospitals and in projects involving mobile devices and sensors. Pedro Duque is the R&D services senior manager at Plux. His background is physics engineering with a master's in biomedical engineering. And he has more than 14 years experience with high-tech environments, from project management to business development. And along the years, he has moved from R&D engineering, mostly electronics, to managing teams, and from the space sector to wearable biosensors. So we'll have this presentation shared by these two panelists. So thank you both for sharing your work with a much broader it's a work from a much broader team, but still thank you very much for being here and representing this work. And I invite you to share your screen. I think you have already. So thank you once again, and you may start.
Thank you, Patricia. Thank you so much for the introduction and the invitation. Good afternoon to everyone. I will give you an overview from a manufacturing point of view on this complex system that Ricardo already explained. I will tell you about, just let me see, tell you a bit about what is this wearable devices and health monitoring. Why this is a closed world to this integration point of view. But how can we bring these devices into the healthcare and comply with this interoperability that was described? And I will also give you a brief view on some projects that we are already testing and making some proof of concepts of such solution. And in the end, I will have some statements for some conclusion and challenges that we face. So we all see this, a lot of wearables coming out in the market. So pretty much everyone today has a watch that it's able to measure the heart rate, for example. But this, generally, manufacturers provide these closed solutions from the point of view of the health monitoring. So they have their own proprietary Bluetooth protocols or device protocols, their own APIs. And this means that they usually choose to supply the hardware, the sensor, together with an app, and it's a closed environment. And why do they do this? Yeah, they usually do it because it's a lot easier. So it's easier to protect the data reliability, so no one is messing around with the data. So they understand really what they are getting from the hardware. Sometimes they do some processing in the app to improve that data. They also guarantee that they ensure their best user experience, so like they envision in the product. It's easier to comply with certification issues. So if they want to go for a medical device, they have to get a closed ecosystem. And also it's actually less costly and easy to maintain during the product lifetime. So they know all the versions that are out there, and they can monitor and control these hardware and software versions. So the question here is that this brings some tough constraints and difficulties for these new telemedicine and remote monitoring solutions that everyone wants to go now. We experienced this during these pandemics, that actually we need a lot of these telemedicine and remote monitoring solutions from the market, but with these closed environments from the manufacturers, it's harder to being directly integrated in a hospital system like Ricardo presented before. And what it's our solution, what it's Plux doing to tackle this. So Plux is a Portuguese company that's already has 14 years experience in developing sensors on the physiological biosignals area, so physiological sensors. We already have an open view on giving the access to the data and integration of our sensors in the third-party softwares. But what we are doing now is that we are getting all other devices. So, for example, with partnership with this company, Biwal Connect, that has the standard devices that people know. And we are integrating these devices in our own software solutions. So together with our portfolio on these devices, we think that we can tackle this opportunity to improve the data gathering at home or even at the hospital. And how are we doing that? So actually, we are developing an app that we call it the Monitor, or you could say that it's a gateway app that actually facilitates and solves all the issues of connecting to these devices. So we are able to integrate their protocols, the Bluetooth connections, and we can prepare this data to deliver them directly to these servers. This data will be actually formatted in a way that it's understandable by the servers. In this case, we are using HL7 Fire. When this data is out there, it's the world that Ricardo showed. So you can do everything with this data. You can integrate it in a hospital information system, or you can integrate it in other apps and other solutions. So in our app, what we propose to do here is we have this large portfolio of devices, and we can, with our app, manage the connection of those devices. So we handle everything, the pairing with the device. We handle the acquisition of the data according to what has been prescribed. We can or not identify the user. So this is the question about the GDPR also. But we will do our own data interpretation and data processing if it's needed. So in the end, we wrap all this data. So we understand this data. We understand what is a blood pressure monitor data, what is an ECG data. And we can extract, for example, a heart rate and make this wrapping for the fire interpretation. And then we'll also manage the connection to these servers. And on top of that, we can have some user interface if it's needed, and interfaces like supporting the user to correctly place the sensor. So this is something that we give a lot of importance is how the users use their own hardware and correctly use it. So when they are alone at home, they absolutely have sure that they get the proper data in a most reliable way. So the app can also support on that. So what projects are we using to test this solution? So we have a couple. The first project is one that actually gave the title to this presentation. It's a joint venture on Health Cluster Portugal. It's a smart health network. So we are a set of companies and entities that join together every week, and we brainstorm on some ideas, and we came up with this joint venture solution where everybody is putting some contribution there to make this final potential product. And in this case, we are doing this chronic disease management platform that actually it's a platform and ecosystem to help monitoring chronic obstructive pulmonary disease, so COPD, and improve this diagnosing and make a way to react quickly to any change when people are followed by the hospital or a clinic. They can go home and they can be still monitored remotely with this chronic disease. So what we plan to put here on the innovation is really this real-time diagnosing and data acquisition from these sensors and wearables. So we almost have an agnostic view on what devices can be integrated. So we are trying to accept as many devices possible to contribute for this data, and then we integrate the data on these dashboards for doctors to access and monitor the patients. Some of the goals, like I said, it's this web interface for the doctor to have a personalized and just way for each patient. And we are planning for this proof of concept to measure oxygen saturation, respiratory rate, for example, respiratory capacity, so the volume of the lungs, and also the activity monitoring. So we will, for example, integrate a Fitbit bracelet to monitor the steps and the daily activity of these people. Also weight monitoring. So it means that the doctor can see the critical parameters, the vital sign parameter, but also can cross-check with the general activity and make a bidirectional interface with the patient and say, okay, you have to improve your daily activity, so you have to move more, or you have to make a walk because your blood is, or you have high tension, something like that. So this bidirectional communication will be possible. This is some of the screenshots that we already have. So it will actually a set of devices that people bring home. They will have this app that will make the bridge between the devices and the HL7 Fire ecosystem. And the clinical will have this dashboard for the remote monitoring and data processing. So this will be a continuous monitoring of the patient. It will increase a lot the data acquisition from the physiological data. So this will be something new, will increase greatly the amount of data that physicians have access to. So this is something that also Ricardo mentioned. These new solutions will increase a lot the data that hospitals are getting access to. This can also improve the insights on disease and some patterns that can be described or defined. So we see here also an opportunity. Another project that is already ongoing, it's the Easy Health for COVID. So this was a project funded in the National Innovation Ecosystem. So we have some partners here. Value for Health, it's a collab dedicated to measuring the quality of health provided to people. We have a company, Future Healthcare, Plugs, our own company, and Healthy System. So what we are doing here is that we are measuring or we are monitoring elderly people at the nursing home. So this was for a COVID-19 scenario where people cannot access direct healthcare because they were in a lockdown, for example. We can provide telemedicine service to these people at the nursing home and also measure daily or even more rate, the daily basis, the data from these people. And the doctor in the dashboard remotely can access and can interact with the nursing home to support them during this lockdown, for example. So the project is quite advanced. We are starting the testing pilot later this month. And you see here you already see some screenshots on the app. We have some devices already integrated. So blood pressure monitor that, for example, the person only has to put the sensor and the app will automatically insufflate and measure the blood pressure. So no need for any additional interface. We will also measure the oxygen saturation, temperature, and glucose. One other project that we are setting up, it's this, we call it Safe Pregnancy at Home. It's basically the same strategy, the same approach, but to monitor pregnant women from early stage to actually to the delivery. So it's for women that have diabetes or hypertension during the pregnancy. So they have to go to hospital in a high periodic rate. So what we are aiming here is that they can do the measurements in the home. They can be monitored remotely. They don't need to go every week, for example, to the hospital if it's not needed. So this is also a project together with Healthy System, Virtual Care, and Plex, and we are trying to evolve this. So some conclusions, also, if you want to generate some questions also. What we see here in challenging is the literacy on the user in terms of technology. So a lot of these end users are elderly people. They have some issues using smartphones or tablets or these devices. So we have to find ways to ease this experience. The devices complexity. So some of devices can be quite hard to interact and get the proper data. So again, it's a challenge for the manufacturers to design devices that are easy to use. Also, the smartphone and tablet dependency to make this gateway to the internet, so to have access to HL7 and Fire. Actually, this is something that we have to aim in the future to put the devices itself, and this is already being done. It's able to communicate via Wi-Fi and directly access the Fire service. There are not much devices that allow integration. So you see, for example, Apple Watch, Samsung, they all have solutions on wearables that get clinical data, but they are not that open to integration. So this is still a blocking point. And sometimes you have licensing fees for APIs and SDKs. And also could be an issue, and this is more for Ricardo to try to answer how we can tackle this. It's this huge amount of data that will generate for these hospital information systems, and also how we can in the future stream live data, for example, as an ECG with these type of protocols. Usually these wearable devices, they make a discrete measurement on a single slot of time, but we have a lot of physiological sensors that they directly stream a lot of data, raw data, for example, the typical ECG signal, that in the future might be interesting to get it in a real live view mode. And that's it from my side. Let me know if you have some questions. I have also my email here if you need additional information. Thank you so much.
Thank you, Pedro. I would ask Sarah to go forward with her presentation, and maybe we'll have some time for discussion in the end.
Okay.
So.
Hello, everyone. Are you already seeing my screen?
Yeah, we are.
Yeah, okay, just a moment. Okay, good afternoon, everyone. First of all, I would like to thank Health Cluster Portugal and also Professor Ricardo for the opportunity to be here talking about this chronic disease management platform that I've been working on. And following these previous presentations, I will now focus on the use of Fire as the chosen standard for this particular project. And particularly, why did we choose Fire? What is it? And then I will explain briefly some of the main work that has been done to get the devices to use Fire. So the first question one may ask is, why do we need standards at all? A standard is a pattern or a model that is generally accepted, and data standards are a set of rules that allow data to be shared in a uniform and consistent manner. And the use of these standards facilitates the integration of data between different information systems. And I have this picture here in the left side that shows 5 different systems that are not using standards. So they are communicating in a point-to-point interaction with each other, where they have to map their variables with the other systems. So in this case, as you can see, there are a lot of arrows in here, which means that this is a very complex process, and this is only for 5 systems. So the more interfaces and the more data fields that are needed to be exchanged, the harder the problem gets. And it gets really hard, and it's really fast, because this complexity grows exponentially. And in the right side, I have the same 5 systems if they are using standards. In this case, each one of them has to map their variables to one single standard. So in this case, we only have 5 arrows for 5 systems. So in this case, the complexity is much smaller. And so now, being clear the importance of the use of standards, comes the question, why did we choose FHIR? HL7 represents the core of standards-based interoperability, including the health data exchange standards like version 2, version 3, or even CDA. And these are all widely used, but they have their flaws. For example, version 2 is since a long time, as Ricardo mentioned, from 1989, it is very successful, but its technology it's old, and it's not suitable for the latest requirements of the healthcare. And version 3, on the other hand, is based on a robust model, but it was not widely accepted because it is much more difficult to implement than version 2. And then we have CDA, which is the Clinical Document Architecture. It has been also very successful, but as the name suggests, it's only for document exchange. So it does not fit well in all scenarios that are needed. And also, in the past couple of years, there are new use cases that involve those mobile devices and sensors that have already been mentioned, that none of these standards were proper for these use cases. So in around 2011, the HL7 asked, if HL7 were starting afresh today, what would the interoperability standards look like? And the answer is mainly focused on the use of modern web-based communication technologies, such as HTTP, XML, or JSON, that in this case are suitable for those mobile devices that I've mentioned. And from that, FHIR emerged, and it stands for Fast Healthcare Interoperability Resources. And it consists of 2 main parts: the content model in the form of resources, and also the specification for the exchange of these resources. So the resources are XML or JSON modular components that form the building blocks to store and exchange the information using FHIR. I have here on the left one example of one resource that is a patient resource in HL7 is similar to one segment. In this case was the PID segment, PID segment. And this, as you can see, it's much more readable, human readable. It's more clean than HL7. And for the information exchange methods, FHIR supports architectures based on REST, messages, and also documents. And FHIR has been widely adopted worldwide, and has been considered a standard very proper for these use cases of mobile devices. And also, big companies like Apple and Google are already on board. So that's why we decided to, from the beginning, to use FHIR in this type of projects. So now I will be presenting the steps involved in the course of the project. I will explain for the chronic disease management platform, but it's similar for the other project that Pedro mentioned, the Easy Health for COVID. First of all, we had to get the list of companies and devices that were entering the project. And after that, we started by asking them what they used by then to store and communicate their data, to know if they already implemented any of the mentioned standards. And the answer for that is none of them used even nor HL7 version 2 or FHIR. And at the time they were using their own formats. And this is very common, and at the same time it's very bad, because companies should be aware not to take this approach to use their own formats, because it holds them back and makes it quite impossible for them to easily integrate with other systems. However, all the devices by themselves or by a mobile app were already able to communicate through HTTP, which was an advantage. Next, we started the mapping to the FHIR resources. First of all, we had to align with each of the companies which variables they wanted to exchange to be available to the platform. And we have here a list of the devices, as well as each one of the measurements from each device. We selected the FHIR resources that were more appropriate for each measure of the sensors. And as you can see, we were able to fit all of the measurements in the same FHIR resource, which is the observation, which is precisely used for measurements and simple assertions made about a patient, device, or other subjects. And regarding the variables exchanged from the devices, it is essential that each measurement of the sensor is coded according to an internationally accepted terminology, such as LOINC or SNOMED, for example. Like, for example, we have here respiratory rates, and we can say that probably every medical doctor understands what that means. But however, to be as clear as possible, and to avoid any misunderstandings on translations or some other issues, companies must define each measurement according to this type of terminology. So this was other work that we have been doing with the companies of the devices. And also here is an example of the resource observation that the companies mapped to FHIR. And FHIR allows a long list of elements inside one single resource, but we decided to define a list of the required elements to be sent by each one of them, even though they might not be required by the standards. And why did we do that? Because this way the company that is receiving all the devices data knows exactly what to expect, and it has a pattern. And on the other hand, if some other new devices want to join in the project, we can say, okay, you can join by just exchanging this type of data and with these particular variables, and it's much more easier for them to join. And then we helped each one of the companies of the sensors to construct this type of resources correctly, of course, according to the standard. And then they started to test on a mock FHIR server that we created for testing purposes, so that every entity could try and exchange information with it from their own devices. And now we have been monitoring this and getting in touch with them to rearrange some of the content. So the devices are sending their data through using FHIR to the integration bus, and also that data is being sent using Fire to the final platform of the dashboards. And soon we'll be performing a proof of concept in a Portuguese hospital for the chronic obstructive pulmonary disease. And for that, we detailed the workflow involving the sensors through some storyboards, including the enrollment process of the patient, the setup of the devices, and then the monitoring of each patient in their homes using the devices. And then in case of any abnormal values or the absence of values being collected from the devices, an alarm is triggered to the project team. And in using these storyboards, we are now finalizing some issues regarding patient identification and the enrollment methods and the communication flow for each device to initiate the proof of concept. The main obstacles that we faced during the project was in the first place, the lack of knowledge of the FHIR standard of most of the entities, because none of them were using it. And because of that, the process of implementing the standard was a bit slow. And also, as I previously mentioned, a good implementation of the FHIR requires the use of terminologies such as LOINC or SNOMED, and they were not doing that by then. So this turned out to be another weakness of the project partners. And also, it's important to mention that this is not a technological issue, but rather a clinical one. So it should be done, or at least supervised, by the clinical team of each of the companies. And finally, the desired scenario, as has been previously said by Ricardo and also Pedro, we want to have the data from the wearables and medical devices and other sensors available to health providers and the medical records. Also, which means that we want to step up from having all the data inside each company and have sort of a plug and play interoperability using those devices. And it's envisioned that these workflows would flourish using the HL7 FHIR. So to get there, companies must be qualified for FHIR. And to use that, they must have the know-how of the standards, because trying to use the standard without the proper knowledge of it has its associated risks as well, because they can exchange data using incorrect resources or improper elements, which then may lead to misinterpretation of the clinical information. So every entities that are working on this field of wearables, sensors, or medical devices, it would be important for them to have training in this area of interoperability, and also particularly in FHIR. So FHIR training and also FHIR certification would be important, so that they can show the world that they have the standard. For example, when trying to sell the devices or showing them in international events, and this way they can expand abroad, because they can talk an international language of interoperability. And also, by knowing and using the standard, the Portuguese companies can also have the ability to identify new requirements that the standard should support, and help in the standard expansion. And I think that's it. Thank you for your attention, and I hope you enjoyed it.
Thank you very much, Sara. Thank you very much, Pedro, for this very clear and illustrative applied examples that you shared with us. So we are a bit behind schedule here, so I'm not sure if there are any questions from the audience. Miguel. Can you see?
We have no written question, but I think we have Renata asking to make a question. I don't know if
Patricia, may I just make a very small, fast comment?
Yes, of course.
Because it's something that actually I forgot to say in my presentation. I think it might be useful for others. Is that we have a Portuguese chapter for HL7, and so well, if you want to know more about these standards or be engaged with the community to work with the standards, well, there's a good way to do it is to try and get in contact with us. It's fairly easy. The web address is hl7.pt, so it's easy to, well,
It
I've
has,
already
it has been shared in the chat. Yeah.
Okay, so just to give you this this idea.
Okay, so we have here Renata Gomes asking to make a question. So I would ask her to please share her question in the Q&A. Okay, so we have one question from in the Q&A. So the question is, how do FHIR relates or integrates with DICOM on image data?
Well, I can try to answer. I don't know if Sarah or Pedro want to. They can also interrupt me, but typically they are used for two different things. Well, DICOM typically is used, well, for systems that work with image, and FHIR, at least now it's in Portugal, is getting used more for smaller types of data and not that related with the image. Although it is possible to use both, okay, but normally they are not that used. So the use cases typically are different one from one and another. Okay.
Okay. So I have one question, and I was picking up on Sarah's presentation. You just mentioned that when you started this chronic disease management platform project, none of the companies had were actually using standards, right? So why do you think this happens? Is it a matter of what is holding these companies back? So is it a matter of lack of awareness, or is it just because it's too time consuming and these companies are small and they don't have the resources or the knowledge to do it? What is your feeling by working now more closely together with all these companies?
I think Pedro mentioned some of those topics in his presentation. I think the companies, some of them are not aware of FHIR yet, and some of them are just too close on itself and are not even trying to put the data to other systems. So I think they are not thinking on that issues yet. But Pedro has some other point of view.
Yeah, it's like you said, Sarah. Actually, it's a lack of awareness a bit. And also, sometimes you miss a use case to go and test your HL7 integration or FHIR. So, but I think the main point is a lack of awareness, and also the chosen path that you have a closed environment and you control everything. You don't want to export data.
Okay, thank you.
This is a mindset is changing, I think.
Okay, so if there are no other questions, I would end by just sharing my screen where you will see this this QR code where you can keep up with the upcoming topics of this webinar series. So I would thank you once again for participating in the webinar. And again, ask also thank also the speakers for sharing with us their knowledge and their perspectives. You may also follow us through LinkedIn or Twitter to be aware of the topics of this webinar series. And next week we'll have at the same place and same time, a topic on preclinical research, novel approaches and trends. So hope to see you there. And I wish you all a very pleasant week, and thank you.